All right, today we're diving into a really complex group of diseases that basically turns our lungs' delicate support system into stiff, scarred tissue. It's called interstitial lung disease, or ILD, and it all starts in a part of the lung that, honestly, most of us have never even heard of. So, to really get a grip on how these diseases mess with our breathing, we first have to explore this hidden framework inside our lungs. So, what exactly is this secret scaffolding that holds the whole operation together? And that brings us right here, to our first section. Before we can understand the disease, we have to understand the location. We're zooming way in on a part of the lung called the interstitium. So, what is this interstitium? Well, think of it as the unsung hero of your lungs. It's this incredibly delicate, spongy mesh of connective tissue that gives all the support to the millions of tiny air sacs, the alveoli. This is where the magic of breathing actually happens. And the interstitium is the essential scaffolding that makes it all possible. Okay, so now that we know where we are in the lung, let's talk about what goes wrong. The core problem in a lot of these diseases is a process called fibrosis. It sounds complicated, but really it's just a medical term for scarring. And this slide just shows the difference so clearly. On the left, you got a healthy lung. The interstitial tissue is thin, it's flexible, it stretches easily like a balloon. But with ILD, like you see on the right, you get this chronic inflammation that leads to scarring that just won't go away. That delicate mesh becomes thick and stiff, and it makes it incredibly difficult for the lungs to just expand and do their job with each breath. And this is what that damage actually looks like on a high-resolution CT scan. In a lung with advanced fibrosis, the normal, healthy architecture is basically destroyed and replaced by all these little cystic spaces. Doctors call this a honeycomb pattern, and it's a classic telltale sign that the lung's delicate scaffolding has been permanently damaged. All that physical damage actually creates a very specific sound. It's pretty wild. When a doctor listens to the chest of a patient with this condition, they often hear something described as fine crackles, something that sounds a lot like Velcro being pulled apart. That is literally the sound of those stiffened, scarred air sacs popping open with every single breath. So the big question is, what causes this devastating scarring? Well, this is where things get really complicated. See, ILD isn't just one single disease. It's a massive family of over 100 different disorders. And the triggers for the scarring, they're all over the map. But we can kind of group the causes into three main buckets to make sense of it all. In about half of all cases, the cause is completely unknown. That's what we call idiopathic. The other half is pretty much split down the middle between the body's own immune system attacking the lungs and damage caused by stuff a person is exposed to out in the world. So let's start with that biggest mystery, the idiopathic cases. The most common, and frankly the most serious form, is idiopathic pulmonary fibrosis, or IPF. In this disease, you get this progressive, relentless scarring, and we don't have a clear reason why. It's what's known as a diagnosis of exclusion. Doctors have to rule out every single other possible cause before they can land on IPF. Next up is autoimmune-related ILD. You can think of this as a case of friendly fire. The body's own immune system gets confused, and it mistakenly identifies the lung tissue as some sort of foreign invader and attacks it. We often see this in people who already have other autoimmune conditions, like rheumatoid arthritis or lupus. And finally, we have causes that come from the outside world. Inhaling harmful substances over long periods of time, things like asbestos or silica dust, can definitely trigger fibrosis. But it's not just environmental toxins. Some life-saving medications, including certain chemotherapy drugs and even some antibiotics, can have the rare, terrible side effect of causing lung damage. Same goes for radiation therapy to the chest. So, with so many different potential causes, how on earth do doctors figure out what's going on? It's really like a piece of detective work, following a path of clues to finally arrive at a specific diagnosis. This diagnostic journey has several key steps. It always starts with a clinical exam, right? A doctor is looking for those classic symptoms like a dry cough and shortness of breath, and of course listening for those telltale Velcro crackles. Step 2 is a high-resolution CT scan, which is the absolute investigation of choice to see the specific patterns of lung damage. Third, they'll do pulmonary function tests, breathing tests, to measure lung volume and how well everything is working. And then finally, in some cases, a lung biopsy might be needed, where a tiny tissue sample is taken to confirm the diagnosis under a microscope. And that high-resolution CT scan is just so central to the diagnosis because different types of ILD create very distinct patterns of damage.
Radiologists are trained to spot these visual clues, whether it's those hazy, ground glass areas, a net-like pattern called reticulation, or the advanced honeycombing we saw earlier. Every single pattern is another clue that points them toward a specific diagnosis.
And finding that specific diagnosis is everything. Because once a lung is scarred, that damage is permanent. The goal of treatment isn't to cure, but to manage the disease. And how you manage it depends entirely on the cause. So this is the crucial point here. One size does not fit all. You absolutely cannot treat ILD without knowing precisely which type of ILD you're dealing with. The approach has to be completely tailored to the underlying cause and the specific pattern of the disease. And this table right here illustrates perfectly why that specific diagnosis is so critical. Let's compare two types of ILD. For the outcome, idiopathic pulmonary fibrosis, IPF, shows a progressive decline. But sarcoidosis, it can often go into spontaneous remission all on its own. Now look at the prognosis. The difference is just stark. IPF has a median survival of just 3 years, while sarcoidosis has a very low mortality rate. And finally, the treatments are completely different. IPF is managed with antifibrotic drugs to try and slow the scarring, while sarcoidosis is treated with steroids, and only if needed. We're talking about two fundamentally different diseases that require completely different strategies.
So the overall goals of management are really clear. First, you use targeted therapies to slow down that scarring process as much as you possibly can. Then you focus on managing symptoms to improve quality of life. That means things like pulmonary rehab and oxygen therapy. And finally, in very advanced cases, assessing a patient for a lung transplant might be the only remaining option.
And this brings us to one final, crucial question. For now, we're basically treating the fire after it's already started. But what if we could prevent the spark? As we get better at unlocking the genetic and environmental triggers, the real challenge for the future is this. Can we one day predict who is at risk and stop the scarring before it ever begins? Could we preserve that delicate scaffolding that allows us all to breathe?